Attention Deficit Hyperactivity Disorder by Carla Gibson and Kaylee Mondrick.
Our targeted audience will include physicians, physician's assistants, advanced practice registered nurses, licensed practical nurses, social workers, and any healthcare professional that will be working with this population. By the end of this presentation, the viewer will understand the neurobiology of ADHD, identify the signs and symptoms of ADHD, be able to diagnose and treat ADHD using both pharmacological and non-pharmacological methods. Pre-test evaluation. Number 1, what is the typical onset of ADHD? Number 2, what race ethnicity is most likely to be diagnosed with ADHD? Number 3, what causes ADHD? Number 4, what are the signs and symptoms of ADHD? Number 5, what are 2 medications that are both short-acting and long-acting? Neurobiology, Neuroscience of Adhd.
Attention Deficit Hyperactivity Disorder, or ADHD, is a condition that causes both kids and adults to be easily distracted, fidgety, and impulsive. What looks on the surface like a behavioral problem is actually a brain disorder that affects both the structure and function of the brain. Research has found that the brains of people with ADHD are smaller in certain areas, especially in the frontal lobe, affecting impulse control, concentration, and inhibition. Brain development is also slower in people with ADHD. The neural pathways don't connect and mature at the same rate, making it harder to pay attention and focus. This can impair executive function, which handles organization and routine tasks. ADHD impacts brain chemistry too. People with ADHD may have problems processing dopamine, a chemical linked to movement, sleep, attention, and learning. ADHD can be tricky to diagnose and challenging to manage, but there are treatments that can help. Consult with a doctor for all your questions about ADHD.
Attention Deficit Hyperactivity Disorder is the most commonly diagnosed neurodevelopmental disorder in children. From 2011 to 2012, 6.4 million were diagnosed, and of that, 13.5 million were treated. The estimated number of children diagnosed with ADHD, according to a national 2016 parent survey, revealed 6.1 million, only a small decrease from 2012 statistics. Of that 6.1 million, it was further broken down by age groups, with 388,000 children being between the ages of 2 to 5, 2.4 million children being treated between the ages of 6 through 11, and 3.3 million of those children between the ages of 12 to 17. ADHD incidence rates are 5 to 10 times greater in the United States compared with other countries. 2 studies were conducted. The first study was done based on race among 3 to 17-year-olds. It revealed that from 2016 to 2018, non-Hispanic Black children were the most likely to be diagnosed with ADHD at a rate of 16.9%, while non-Hispanic whites were lower at 14.7% and Hispanics even lower at 11.9%. The second study conducted broke down into 2 age groups, 3 to 10 and 11 to 17 years of age. It revealed that from 2016 to 2018, non-Hispanic Black children aged 3 to 10 were the most likely to be diagnosed at a rate of 16.9%, non-Hispanic whites at 14.7%, and Hispanics at 10.1%. Non-Hispanic Blacks age 11 to 17 were at an even higher rate at 21.6, while non-Hispanic whites were only at 19.7 and Hispanics at 14%. Across the board, regardless of age, non-Hispanic Blacks were diagnosed more. However, as far as treatment, the statistics reverse. Cultural differences in prescribing stimulants were reported in the same study, and actually by 5th grade, 18 to 20% of non-Hispanic whites were prescribed medications like methylphenidate, whereas rates were significantly lower in other ethnicities, especially non-Hispanic blacks. Among children living in families at less than 100% of the federal poverty level, non-Hispanic whites were more likely to be diagnosed with ADHD or a learning disability than non-Hispanic blacks. Similarly, among children living in families at 100% or more of the federal poverty line, non-Hispanic white children were least likely to be diagnosed with ADHD, and non-Hispanic black children were more likely to be diagnosed with ADHD. In regards to Hispanic children across the board, all rates were lower. It can be concluded that blacks and those from poverty-stricken areas are more likely to be diagnosed with ADHD, but less likely to be treated effectively. There's an association between ADHD and various comorbidities. Research shows a higher number of psychiatric comorbidities that include depression, anxiety, obsessive compulsive disorder, oppositional defiant disorder, and conduct disorder. A study also concluded that epilepsy is now linked as a comorbidity to ADHD. In one study of 23 patients with epilepsy, 19 of them had ADHD symptoms preceding the onset of their seizures. Other comorbidities include learning disorders, eating disorders, sleep disorders, and even enuresis. As healthcare providers, we must identify these comorbidities and treat them accordingly. The hallmark signs and symptoms of ADHD are centered around three distinct characteristics, which include inattention, hyperactivity, and impulsivity. See the next slide to see ADHD in action.
Good afternoon, Mackenzie and Miss Gibson. How are y'all today?
Hello, we're good.
So, what brings you in to see me?
Well, we need your help. Mackenzie's grades are declining, and home life, we'll just say it's rough. She constantly just, I don't know.
It's virtual school. That's the problem.
No, it's not just virtual school. We have had this problem for a long time now, and it just seems to be getting worse. We've been to 2 other psychiatrists, and we've been told that she has conduct disorder. We've been told ODD, but it's not just that. Mackenzie just can't focus. She just can't sit still. It's just,
I just get bored.
Well, Mackenzie, what do you mean you just get bored?
See, I dance, but I don't want to dance all the time. And I do makeup, but I don't want to do that all the time.
no, it's not that. She does get bored. She doesn't get bored. She just can't focus long enough to complete a task. And then when she gets angry and frustrated when you ask her about completing something, and her defense mechanism is, I get bored. And as far as school, school is just,
How long is this gonna be? Yeah. You know what? I'm just gonna go in my room and make some TikToks.
see, this is what happens all the time. It's just like she can't sit still. And then, I get aggravated, and I think the reason why she gets aggravated and when she gets angry, they say the ODD and the conduct disorder because of disruptions with school and the arguing and the fighting with their siblings, and it's just spiraling out of control. I'm just frustrated, and I just don't know what to do. I don't know to punish her, time out, what.
Yeah, I mean, I totally understand that you're frustrated, but if it's okay, I'd like to continue asking you some questions.
Sure, that's fine. I just want my daughter to be back to normal.
Okay, okay. Well, let me ask you some questions. So I'm going to ask you to rate these. How does Mackenzie get along with other people? Like, does she have any siblings?
Yes, she has siblings, and it's not good.
It's not good. Okay. Does she make friends easily?
Actually, yes, but they just don't stay friends long.
Oh, okay. Okay, so she doesn't have long-term relationships or friendships.
No.
Okay. Okay. And what grade is she in?
She's in the 6th grade.
Okay, 6th grade. Has she ever been in any type of special education?
No.
Okay. Has she ever been diagnosed with a learning disability in the past?
No.
Okay. Has she ever been suspended from school, retained in a grade level, anything like that?
She had to go to summer school one time, but then she was able to do better and pass those classes, so she moved on, and she started with suspensions her 5th grade year.
Okay. So she started with suspensions last year. Okay. Okay, so can you tell me about how has she progressed over the years? Starting back as far as you can remember, and when these behavior issues, or I guess the lack of attention, lack of focus issue began.
So preschool was okay. Kids aren't able to sit still anyway. So teachers were like, "Oh, she's just a normal preschooler." Kindergarten was okay as well. Teachers would say, "Oh, that's just typical. They'll start to learn, and we'll start to enforce, structure." 1st grade and 2nd grade were okay. We had the minus marks in conduct here and there. But as she started to get to 3rd and 4th grade, when there was really more structure, that's when we started to have the disruptions, in school, the talking back, and just, I think when she gets frustrated, then she just acts out. The lack of turning in her homework and the school assignments. Her grades were okay. We had that issue with her almost failing a grade, but she did just enough to get by, to get through and not be retained. And then 5th grade just kind of, everything just kind of blew up. The constant issues being in the office, the grades just, dropping, and that's when she had to do the summer school in order to pass to, be moved on to 6th grade. And now that we're in the 1st year of middle school, it's just horrible. She has D's and F's, and it's just like, the teacher's at a point where she's like, she cannot stay focused. She cannot complete her assignments. She does not complete her assignments. And they basically were like, you need to go see a doctor to get her evaluated.
Okay. You think she's getting frustrated, like her behavior is because she's getting frustrated with the schoolwork and, not being able to focus? Okay. Okay.
And it spills over to at home as well. I'm sorry, at home not being able to complete things, and I would tell her to do this, this, and this, and it's just like she's all over the place.
All over the place. Okay. 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 So, what would you say are your top, behavior concerns, like as far as like at home and at school?
Her lack of focus and her ability to not be attentive causes her academic and behavior problems. So if we can get her focused and not be so impulsive and just all over the place and just at a happy balance, I think the academics would improve and the behavior would basically cease, because I think it's spiraling because of the lack of focus and the ability not to be attentive.
Okay. What strategies have you used to try and work with her on her behavior?
When she was younger, we would do timeout. As she's gotten older, we try to do, we'll take away your phone, we'll take away your, TV privileges, taking away, different little things when you don't do this and this. But then sometimes that just causes the behavior to be worse. So sometimes we just give in and just take it for what it is.
So how consistent are you now, and have you been with doing these things?
Not as consistent as we probably should be, because it doesn't seem to be helping.
Okay. And what does she say about it? Does she think that, she needs to do something to help her focus? Like, is this something that bothers her?
Sometimes she will say it, but sometimes she's so defensive about it. Like, I don't know, she feels little bit, but I think sometimes she's just like, I don't know what my problem is. So I think she knows something is there. It's just at that age where kids are cruel, so I don't know if she just doesn't want to kind of say anything, but she definitely here and there just will say she just doesn't know what's wrong with her.
Yeah, it sounds like, her trouble with focus and, inattention is causing her to, her behavior issues.
Yes.
Okay, well, so at what age did you say all these problems began?
I think it became more apparent maybe towards fourth and fifth grade. That's when it just really started to cause a problem when she was needed that more structure.
And her grades kind of started going downhill at that point.
Mm-hmm.
Okay. Okay. Well, Miss Gibson, I'm going to send you some forms via the portal. And I'm going to need you and her teachers that that are having the most difficulty to complete them and turn them back into me as soon as you can. And once this is done, we will evaluate and we will treat from there.
Okay, perfect.
So we can get some answers and get a little bit more focused on what we need to do.
Okay, perfect. Thank you so much. I will get all of that back to you as soon as possible.
Okay, thank you.
Thank you.
History and Physical Assessment. The American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry have developed certain evidence-based practice parameters for the assessment and the treatment of children and adolescents with attention deficit hyperactivity disorder. Components of the assessment include comprehensive evaluation of the child's history, history of academic performance, vital signs, physical exam, and mental health assessment.
The symptoms of ADHD overlap with a number of other conditions, including neurological, developmental, behavioral, psychosocial, psychiatric, and certain medical disorders. Differential diagnoses to consider include intellectual and learning disabilities, autism spectrum disorder, neurodevelopmental syndromes like fetal alcohol syndrome and Fragile X syndrome. Select psychiatric differentials include depression, mood disorders, anxiety disorder, oppositional defiant disorder, conduct disorder, obsessive compulsive disorder, post-traumatic stress disorder, and adjustment disorder. Medical differentials include seizure disorder, sleep disorder, iron deficiency anemia, lead poisoning, endocrine disorders like thyroid disease or diabetes. Other differentials also include substance abuse, food allergies, undernutrition, and medicine side effects. It is therefore necessary to screen and assess appropriately, which leads us to our next slide.
Comprehensive evaluation for ADHD. In-depth interviews should be conducted with the child and their parent or caregiver. Questions to ask are, what are the specific symptoms? When do these symptoms occur? Do the symptoms occur in the same situation or in different situations? At what age do the symptoms begin? How long do the symptoms usually last? Does anything trigger the symptoms? Does anything make the symptoms better? And are the symptoms interfering with functioning? A psychiatric evaluation and biopsychosocial assessment should also be performed and should include the following: prenatal history, developmental history and milestones, medical history, injuries and hospitalizations, family history, co-occurring disorders including learning disabilities, depression, anxiety, poor anger management, and other behavior problems. Academic history that includes successes and challenges, talents, strengths, unique abilities and coping skills, relationships with family and peers, history of substance use, mental status, and temperament. ADHD screening tools should be administered at this time.
There are different ADHD rating scales designed specifically for children, teenagers, and even adults. Common rating scales for children include the Behavior Assessment System for Children, designed for ages 2 to 21, the National Institute for Children's Health Quality, the NICHQ Vanderbilt Assessment Scale, intended for ages 6 to 12, the Conners Comprehensive Behavior Rating Scale, intended for ages 6 to 18, the Child Behavioral Checklist, created for ages 6 to 18, Swanson, Nolan, and Pelham 4 questionnaire, also called SNAP-4 for children aged 6 to 18, and Conners Well Adolescent Self-Report Scale, which is actually specifically for teenagers. Although there are several ADHD rating scale tests available, the most commonly used ones include the Vanderbilt Assessment Scale, which has a parent scale as well as a teacher scale, and the Conners Comprehensive Behavior Rating Scale.
DSM-5 criteria for ADHD. People with ADHD show a persistent pattern of inattention and/or hyperactivity and impulsivity that interferes with functioning or development. Inattention. 6 or more symptoms of inattention for children up to age 16 years, or 5 or more for adolescents age 17 years and older and for adults. The symptoms of inattention must have been present for at least 6 months, and they are inappropriate for developmental level. Often fails to give close attention to detail or makes careless mistakes in schoolwork, at work, or with other activities. Often has trouble holding attention on tasks or play activities. Often does not seem to listen when spoken to directly. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. Often has trouble organizing tasks and activities. Often avoids, dislikes, or is reluctant to do tasks that require mental effort over a long period of time, such as schoolwork or homework. Often loses things necessary for tasks and activities, such as school materials, pencils, books, tools, wallets, keys, paperwork, eyeglasses, and mobile phones, is often easily distracted, and is often forgetful in daily activities. Hyperactivity and impulsivity. There should be 6 or more symptoms of hyperactivity or impulsivity for children up to age 16, or 5 or more for adolescents age 17 years and older and for adults. Symptoms of hyperactivity impulsivity have been present for at least 6 months to an extent that is disruptive and inappropriate for the person's developmental level. Often fidgets with or taps hands or feet or squirms in seat. Often leaves the seat in situations when remaining seated is expected. Often runs about or climbs in situations where it is not appropriate. Often unable to play or take part in leisure activities quietly. Often on the go, acting as if being driven by a motor. Often talks excessively. Often blurts out an answer before a question has been completed. Often has trouble waiting their turn. Often interrupts or intrudes on others, butts into conversations or games. In addition, the following conditions must be met. Several inattentive or hyperactive impulsive symptoms were present before age 12 years. Several symptoms are present in 2 or more settings, such as at home, school, or work, with friends or relatives, or in other activities. There is clear evidence that the symptoms interfere with or reduce the quality of social, school, or work functioning. And the symptoms are not better explained by another mental disorder, such as a mood disorder, anxiety disorder, dissociative disorder, or personality disorder. The symptoms do not happen during the course of schizophrenia or another psychotic disorder. Based on the types of symptoms, there are 3 kinds or 3 presentations of ADHD. There is the combined presentation, If enough symptoms of both criteria of inattention and hyperactivity impulsivity are present for the past 6 months, there is the predominantly inattentive presentation, which is when there's enough symptoms of inattention but not hyperactivity or impulsivity being present for the past 6 months. And then there is the predominantly hyperactive or impulsive presentation, which is where there are enough symptoms of hyperactivity and impulsivity but not inattention present for the past 6 months. Because symptoms can change over time, the presentation may change over time as well. The American Academy of Pediatrics Treatment Guidelines. For children ages 4 to 6 years, first-line treatment is parent training and behavior management. Effective treatment for children with ADHD helps improve behavior and self-control and helps promote self-esteem. Parents learn how to better help their child at home, in school, and in relationships, usually between 8 to 16 sessions. If available, behavioral classroom interventions may be used. This is extra time for children to take tests. Instructions are tailored to the individual child. They receive positive reinforcement. They are allowed breaks and time to move around in school. Their distractions are limited, and they learn organizational skills. For children and adolescents ages 6 to 18 years, the recommended first-line treatment are medications approved by the FDA, which are your stimulants and non-stimulants. Parent training and behavior management and behavioral classroom interventions may also be used in this age group. As providers, we must adjust medication dosages to help patients reach the maximum benefits with the least amount of side effects. Medication for adolescents should be used with their approval.
Medications used to treat ADHD fall under the category of stimulant or non-stimulant. As far as the category of stimulant, there are two types. One being immediate release or short-acting medications, which the most common being Adderall and Focalin, and your older medications like Ritalin. These medications usually last anywhere from 4 to 8 hours. Your second category of stimulant is extended release or intermediate and or long-acting medications, those being Adderall XR, Vyvanse, Focalin XR, and Concerta. These are usually taken once in the morning and do not have to be taken again at school or after school. They last anywhere from 10 to 12 hours. If a non-stimulant is preferred, medications like Capvay, Strattera, and Intuniv can be offered. Non-stimulants are sometimes added as adjunct therapy and have the benefit of lasting 12 to 24 hours. Regarding each category of medications, it is necessary to discuss not to crush or chew extended release capsules or tablets. For the child who has difficulty swallowing, capsules that are made up of beads can be opened and sprinkled onto food. In order to choose the right medication, healthcare providers must consider several factors to ensure the proper medication is prescribed. Look into the duration of desired coverage, whether it be long-term or short-term, meaning 4 to 8 hours, or 10 to 12 hours, or 12 to 24. The ability of the child to swallow pills or capsules, the time of day when the target symptoms occur, the desire to avoid administration at school or after school, potential adverse effects, history of substance abuse in patient or household member. This may warrant the use of non-stimulants and to steer away from stimulants, the preference of the child, adolescent, and his or her parent or guardian, and last but not least, expense. Take all these factors in consideration and then choose a medication that is appropriate for your patient. Overall, it is necessary to treat each individual based on their specific needs and their preferences.
ADHD medication, pediatric pointers. For stimulants, check blood pressure and pulse before starting. Monitor vital signs regularly. Collect a baseline height and weight and monitor periodically throughout treatment. The average preschool child taking stimulants requires a short-acting medication due to lower weight. A baseline EKG should be performed before starting stimulants. Encourage a nutritional diet and exercise regimen. Always check for interactions with other drugs the patient is taking. Adolescents should be educated on the effects of mixing stimulants with alcohol. And monitor appetite at each visit. For non-stimulants, consider a non-stimulant if the patient is unable to tolerate stimulants. These may be suitable for patients with a history of substance abuse, and some parents may opt for this type of medication over stimulants. Non-pharmacological treatment for ADHD. Behavioral therapy consists of parent-led behavioral interventions or classroom-led behavioral interventions, cognitive behavioral therapy given directly to patients, and neurofeedback. Psychoeducation consists of educating the patients, their families, and their teachers about ADHD, done direct from the clinician at consultation, and it can be utilized in group education sessions. Patients can be taught to increase physical activity and make changes to their diet, although there is limited evidence supporting this. Treatment should be tailored to the unique needs of each individual and family to help the patient control symptoms, cope with the disorder, improve overall psychological well-being, and manage social relationships. The theory and nursing model used for this project was the health promotion model by Nola Pender. Health promoting behavior is an action directed toward reaching positive health outcomes, including productive living, optimal well-being, and personal fulfillment. Theoretical propositions chosen for this project are: persons commit to engaging in behaviors from which they anticipate deriving personally valued benefits, and families, peers, and healthcare providers are important sources of interpersonal influence that can increase or decrease commitment to engaging in health-promoting behaviors. Major assumptions reflecting both nursing and behavioral perspectives are: people work to regulate their behaviors, people work to better themselves and their surrounding environment, healthcare providers are a part of the environment, and change of the person and environment that is self-initiated is vital to changing behavior.
The expected treatment outcomes for Mckenzie include the following. Patient will experience improved relationships with parents, siblings, teachers, and friends. Patient will experience fewer disruptive, impulsive behaviors. Patient will complete tasks at home as well as at school.
Good afternoon, Mckenzie and Miss Gibson. Welcome back. Good to see y'all.
Hello.
So it's been 4 weeks since our first appointment, and I just wanted to check and follow up with you and see how the Vyvanse is working. We started you on the 30 milligrams.
I think Mackenzie's doing a lot better. What do you think? Yeah, I didn't realize how unfocused and irritable I was before the medication.
Yeah, I think we're seeing improvement with grades, and of course, home life is great. Her siblings actually like her now, so I think it's going good. The medication is really helping.
Yeah,
Good.
I feel more balanced, but I am having trouble sleeping.
Well, okay, so you got lots of positive, and then, trouble sleeping is a side effect of the Vyvanse and medications like that we use to treat ADHD. Are you having any other side effects?
No, ma'am.
Okay, so just trouble falling asleep?
That's it.
Okay, well, would you be interested, Mckenzie and Mom, in trying something called clonidine? You take it at night. It helps for your ADHD symptoms, and it can help you fall asleep faster. If you'd like to try that at night, is that something you'd be interested in? It's typically used for high blood pressure, but we use it for ADHD.
Okay, that sounds good.
Okay. Well, I will call that in, and it's clonidine 0.1 milligrams. I'll call that in for you today, and then we will schedule an appointment for 4 weeks from now. How's that sound?
Sounds good. Sounds good. Thank you so much.
All right. If you have any questions or anything, just call me and let me know, and we can fit you in sooner.
Okay, perfectly. Will do. Thank you again.
Thank you.
All right. No problem. Glad you're doing so well.
All right, thanks.
All right.
Evaluate treatment outcomes. For your follow-up evaluation, you want to ask about academic performance, homework, and grades. You want to ask about relationships with family and peers, if they've improved. You want to ask about behavior. Has their behavior improved? And of course, you want to ask about medication and any side effects they may be experiencing. This is a list of the typical side effects you will see with stimulants, including Vyvanse. Decreased appetite, dry mouth, trouble sleeping, dizziness, stomach ache, increased sweating, headache, nausea, anxiety, weight loss, and irritability. Here is an ADHD medication side effect checklist that can be given to patients. It asks about appetite loss, trouble sleeping, feeling sluggish, tired, or listless, crabby or irritable, tearful, sad, or depressed, worried or anxious, if there is any motor tics, which are repetitive movements, jerking or twitching, picking at skin or fingers, nail biting, lip or cheek chewing, stomach aches, or headaches.
Research. Current literature is revealing that living with ADHD is posing a significant economic burden. According to a study recently conducted, it is noted that the social and economic cost of ADHD was a little over $12 billion. There is also a direct correlation between children from low-income homes and ADHD. Children from families living below the poverty level and those whose parents did not pursue education beyond high school are more likely to be diagnosed with ADHD learning disabilities, according to a new U.S. data breach statistics that was just recently released. According to the CDC, research proves that stimulants are the best known and most widely used ADHD medication. Between 70 and 80% of children with ADHD had fewer ADHD symptoms when they were taking these fast-acting medications. Also, according to the CDC, behavior therapy, including training for parents, is noted as the most effective form of treatment for all ages. For children with ADHD younger than 6 years of age, the American Academy of Pediatrics actually recommends parents to participate in behavioral therapy as the first-line treatment for their children. For children over the ages of 6, the recommendations include medication and behavioral therapy together. Children with ADHD often show behaviors that can be very disruptive to others, so the combination of behavioral therapy and medication therapy is the best treatment option and should be initiated as soon as a diagnosis is made. The current research out there regarding ADHD is vast, but yet there is still room for more improvement, which brings us to our next slide. There is always the need for further research. A new and upcoming treatment option is neurofeedback. Although there is little information about this viable treatment alternative, neurofeedback allows the patient to learn to self-regulate his or her own brain activity to directly alter the underlying neural mechanism of cognition and behavior. There is very little research out there regarding this upcoming alternative treatment measure. Research regarding understanding the complex mechanisms regulating sleep promotion, wakefulness, and attention may contribute to new insights regarding the core impairments in ADHD and lead to the development of new therapies is also needed. Currently, there is very little research that examines and reveals how school-home relationships affect children with ADHD in both positive and negative ways. Behavioral difficulties caused by symptoms of ADHD are present in both settings, so there is an increased need for research to show the importance of positive school-home relationships and how it correlates to positive patient outcomes. Furthermore, there is definitely a lack of research regarding long-term maintenance of symptoms, remission, and side effects of medications. Further research on the mechanisms of action of ADHD medications is needed to develop better therapies. Pinning down how medications work, as well as the side effects, will help pinpoint possibly developing drugs that will target the symptoms better and least likely to cause those adverse effects. ADHD coaching is a promising behavioral intervention and a useful component of treatment. ADHD coaching is a specialty skill set that empowers patients to manage their attention, hyperactivity, and impulsivity. It is described as a collaborative, supportive, goal-oriented process in which the coach and the patient work together to identify the patient's goals and then develop the self-awareness, systems, and strategies and skills necessary for the patient to achieve the goals and reach their full potential. There is most definitely a need for more research regarding this new and innovative behavioral therapy. Although we have come a long way with the treatment, diagnosis, and screening of ADHD, there is still always room for further development and further research.
Post-test evaluation.
Attention Deficit Hyperactivity Disorder, or ADHD, is one of the most common chronic childhood disorders. Pathophysiology of ADHD reveals both genetic and environmental factors that contribute, as well as the neurotransmitters dopamine and norepinephrine being involved. As far as statistics, current estimates indicate that 4 to 12% of all school-age children may be or will be affected and diagnosed with ADHD. ADHD is a neurobehavioral disorder that usually appears in children at age 7. Children with ADHD may have difficulty controlling their behavior in school as well as social settings and often fail to achieve their full academic potential. Clinically, the child may present with the hallmark symptoms of hyperactivity, impulsivity, and/or inattention. The child may easily be distracted but unable to pay attention and follow directions, be overactive, and/or have poor self-control. The diagnosis of ADHD relies on a thorough documentation of symptoms, a complete physical and history, as well as other things that are associated with functional impairment that includes information from school personnel, family, and even the child's pediatrician. It is necessary for the healthcare professional to know that ADHD occurs more in lower socioeconomic areas and is highest among blacks, but blacks are often the most undertreated and do not receive medication. Be aware of differential diagnoses and take the necessary steps to rule them in or out. Know the most common screening tools for ADHD, with the most widely used one being the Vanderbilt, which is available for both parent and teacher. Once a diagnosis of ADHD is confirmed, a management plan that incorporates the appropriate medication, rather stimulant, non-stimulant, or both, as well as behavioral therapy to meet targeted outcomes. It is necessary to identify other medical, educational, or psychosocial comorbidities that may be causing and/or exacerbating the child's symptoms. Refer when needed. Always monitor your child's progress and support parents in their role as advocates for their child. In conclusion, because no two children are alike, keep in mind that an individualized treatment plan must be implemented so that your patient can reach his or her individual full potential.